Thank you so much, and very good evening to everyone. Thank you for joining this wonderful webinar presentation by two very experienced speakers. Today, I will introduce you to our topic and to our speakers. We will be touching on a business case for adopting an advanced bronchoscopy solution. We have some wonderful clinical insights from Dr. Hogarth and an economic case, how to craft an economic case by Jason Keeler. So with that, let me get started with the introductions to our speakers. First, I would like to introduce you to Dr. Hogarth. Dr. Hogarth is the Director of Bronchoscopy and Professor of Medicine at University of Chicago Medical Center in Chicago, Illinois. He has over 25 years of experience. He's extensively experienced with a variety of advanced technology. You can see up here on the screen from Super Dimension, Illumicide, Monarch, Body Vision, and Archimedes. He's also one of the first robotic users in the US and the first Galaxy robotic user here. He's been significantly published, several trials that he's been involved in, some of which include the Navigate and the MAT study. He is also the founding member and the former president of the Society of Advanced Bronchoscopy. So we are very excited to have Dr. Hogarth talk about clinical insights. Our next speaker is going to be Jason Keeler. Jason Keeler is currently working as the Interim Associate Vice President of Perioperative Services at Northwest Community Hospital. He was formerly the Executive Vice President and Chief Operating Officer at UCMC. He carries with him significant executive experience of over 2 decades, and they will be bringing us a very different perspective within the healthcare system and how we can approach executives when we're trying to make a case for adopting some advanced technology for our practice and growing our lung module program. So thank you very much to both of them in advance. And with that, I will hand it over to Dr. Hogarth to kick off the presentation.
All right. Now, can you see my slides?
Yes, we can.
Hey, how about that? So look, thanks, Praj. I'm really excited about this topic tonight for a lot of different reasons. Those of you who I have the benefit of knowing who are on this webinar know that if you've interacted with me, one of my strongest convictions is understanding the value you bring to the medical center. So I am going to be here to talk about the Galaxy and Noah Medical and the use of this device to fix CT to body divergence, but I'm actually really excited about being able to present with Jason Keeler, because what Praj didn't state was that a good chunk of the success of the University of Chicago's bronchoscopy program doesn't come from me, but it comes from Jason Keeler's prior leadership, because he saw the immediate value, but he also taught me the language of the C-suite to understand the value I brought to the system that could be then leveraged to obviously acquire the technologies that we need to be able to keep moving forward and growing and so forth. So I love the idea of this topic of combining the clinical medicine, the thing that we're all very interested in, but at the same time understanding the importance that you bring as a physician to the medical center, specifically as a proceduralist, and then how the medical center can be made to understand that. Because unfortunately, I think many people on this webinar know, you don't have the advantage of having someone as excellent as Jason who understands what you bring to the medical center at a financial level. He's obviously interested in patient outcomes, but at the same time, his job is to keep the place open. And so that's going to be equally important. So with that background, let me jump into CT to body divergence. Obviously, this is an SAB, it's a sponsored webinar through Noah Medical. I think many of you know I am a consultant for Noah Medical, so I obviously have conflict of interest. So there it is. Let's go through it and kind of help us understand it, because I don't necessarily know if it's something we've all thought about. So I'm gonna show you actually a case. This is a Monarch case, but you can obviously, I'm out in the periphery, and just for the sake of context, before I start the video, you can obviously see the tumor. We've run directly into it. So, but obviously that doesn't happen frequently for a lot of us who've done peripheral bronchoscopy. Even with a scope, you run into the wall, you know the lesion's on the other side of the wall. But I want to put it into context because you can obviously see it, but I want you to understand where the computer thinks I'm located. Okay. So there it is. So right there on top of the lesion. And I'm I'm nowhere near it, according to the computer. Okay. So let's go, and I'll have a still here. I'm looking right at the tumor. And again, in the normal scenario, the tumor's on the other side of the wall. But if you look, this is where I was supposed to be driving. This is where the computer thinks I am. So if I, of course, put my needle through, or more importantly, steered myself towards this yellow ball and put my needle through, I would be missing the lesion. And obviously it's easy when you run right into the darn thing, but that doesn't happen often enough. Now, some people have tried to say that that's an electromagnetic thing, but here it is, of course, case example with shape sensing. And this is not about one technology or another. This is about being in the periphery. So here's an example with the Ion where you've parked yourself right in front of their target, their virtual target, but on cone beam, on mobile cone beam, you can see that the actual targeting, the lesion's up here, and you can see that the needle is nowhere near the lesion. And so you have to then correct and so forth. And of course, you are not driving towards that virtual target. And this has been quantified. Fantastic work from Mike Pritchett and others have demonstrated that with shape sensing and then also with EMN, that the displacement can be quite varied. And look, CT to body divergence on a big lesion probably doesn't matter all that much, because Mike has looked at that. I'm going to skip this video for a second. I'll come back to it, because Mike has demonstrated that with others, Badra as well, and Mattingly, that where the virtual targeting center, where you've always been driving to with whatever system, versus where it actually is in real time. And if you look, there's frequently no overlap. And if the lesion's small enough, you are literally biopsying here, here, or here, but never here. And that's why, despite your so-called navigation success with whatever platform, that never translated into true success of making a diagnosis. The CT to body divergence. So I'll play this video, and it's obviously this is a cartoon or animation, whatever, but this is a scope, any scope. Again, pick a system, it doesn't matter. In this case, it's a robotic one, but it really wouldn't matter. But if you're going to a virtual target and you are, of course, striking what the computer tells you is the lesion. Now, there's a lot of reasons this has failed. CT to body divergence is the biggest one. But of course, lack of reach and stability and vision have been other reasons that have also been limitations, some of which robotics was supposed to help us overcome. But we know through the first generation of robotics, based on this literature, this publication and presentation, and our own experiences in the cases I just demonstrated, these have happened to all of us. So why? And then this is, I think, one of the best things that came out from this work that Pritchett et al. Did to really demonstrate the value of advanced imaging, which demonstrated that in the upper lobes and the non-upper lobes, there's a variation, but there's a big significant difference in divergence. And this really quantified it. And take a look at that for a second in the non-upper lobes, an 18 millimeter divergence on average. If you're biopsying a 10 millimeter lesion, that literally is the difference between biopsying air and biopsying the lesion you wanted to actually sample, right? Now, lots of things that factor into this, and a lot of things have been done to overcome this. Larger volumination, a lot of great work done by Badra, and then obviously some further quantitation by Casal and others to help with ventilation techniques, higher volumes, higher PEEP, breath holds, etc., to help overcome some of this. But this is an inherent problem. So why does it happen? Well, there is atelectasis. Here's a great example, and we know this from the studies that have been published looking at ventilator strategies. Longer you spend, especially on the lower lobes, you start to get atelectasis. Obviously, you're driving through the airways with any form of a scope. Again, robot, non-robot, you're distorting the airways. You're distorting the lung. And that picture of the airways and the lesion you're heading to and where the computer thinks you should be going is predicated on a static image. This would be you're using your GPS to drive and the roads are moving, right? Hemorrhage obviously distorts vision and distorts imaging, and especially if you're trying to use radial EBUS to justify where you're located. And then pleural effusions, changes in anatomy, etc. The simple thing, like we've talked about, that the CT scan was done on an awake, alert patient, total lung capacity with arms above their head, not paralyzed, not sedated. All of that plays a factor. Rebus, hey, that must be the solution, except Rebus is only lateral looking. It lacks directionality. Non-aerated and atelectatic lung can look very much like lesion. And I know everyone likes to talk about how, oh no, I can tell the difference. If everyone could tell the difference, then radial probe localization and navigation success, which in almost every trial has always been published in the high 90s, has never equaled the same as diagnostic yield. Right? These false positive images can also give you this confidence that you're getting good quality tissue, and you're not. So let me introduce you to the Galaxy The idea behind this was to obviously take what we liked about peripheral bronchoscopy, take what we liked about robotic systems, but fix what was inherently wrong in all these legacy technologies and give us a true 2.0 robotic system. I was lucky enough to be the first in the US to have it on May 18th, 23. We started our first cases, and this system gives you image integrated targeting while obviously in a nice small footprint with a disposable scope, which I think is part of what Jason will ultimately be talking about as well. Now, right up front, the idea about overcoming it, there's great literature that if we could integrate imaging, if we could bring in any amount of imaging, we should be able to overcome this. The problem truly is, are you actually integrating it, and are you at the same time also getting augmented fluoro? So here's a classic example. The lesion, obviously, this is a cadaver model, so we've made it easy. You can see the lesion. We can all see the lesion fluoroscopically, but that's not usually the common scenario. You can get by with a simple C-arm using tomosynthesis with a 60-degree sweep minimum. So that is available. You can obviously also use advanced systems. So if you have a 3D system, it will support it. One of the key things about the Galaxy is its ability to integrate any fluoroscopic system. And that allows you to then mark where the scope is, and then you get the reconstruction and you mark where the image is. And what that gives you is two things. You take your scope, you're busy driving, you're moving towards the virtual target, that's what this moon ball is, but you at the same time then get an augmented fluoroscopic image, this blue circle. Now again, we're cheating, we can see the lesion fluoroscopically, but frequently you and I can't. But I can tell you what, I can see the blue circle, and the blue circle has been marked by me. For the first time ever, the augmented fluoro integrated with a robot is the first time that I actually know where the target is right now, because I just did the fluoro. For those that have cone beam, they've had this experience. For those that have had lung vision, they've had that experience, but none of it is being built back into your robotic system and updating your navigation at the same time, and it's all on separate screens. So for example, augmented fluoro can help you locate that lesion, but without augmented fluoro, you can see it here, but with augmented fluoro, you know you're in the blue circle. But what I want to really draw your attention to, quite frequently, even on a lesion you can see, many of us think we're in it. And in one plane, we sure are. And then as we rotate around, you can see how much you're missing. So one of the things that's really interesting about this device was to quantitate this tool in lesion tomography. They branded as strike point, but this is a common scenario that you and I have put a needle out into the virtual target, and in reality, we're not in the real target. So how about we quantify this? And if you look at this video, you can see the lesion with the tool out, but more importantly then, when you zoom in on or bring into center view the lesion or the needle, you see that not only are you not in the target, it tells you how far away you are from the target so that you can make appropriate adjustments to then achieve a center strike and get yourself to being tool in lesion for real. Not tool next to lesion, not tool tangential to lesion, but tool actually in lesion. So I'm going to give you a case example real quick. There's one of ours, a 67-year-old smoker with a 9mm right upper lobe nodule right there on the medial surface, surrounded by a lot of emphysema, poor performance status. It's PET positive. Okay, great. You know, we all have situations like this. So what do you need to do here? So I'm going to show you in real time on our first pass of our forceps. This was a 12-minute total case. So right here, I'm pushing the forceps out. I'm now making minor adjustments to get this white ball dead center. Now, you look over here on fluoro. In 2D, my forceps are now in the blue circle on the AP plane, but I could be behind it. I could be in front of it. So we're going to look at another plane, and I'm in the blue circle. I'm going to rotate back to AP. I'm going to rotate out to another angle, and in all three planes, my forceps are in that circle. So I take my biopsy, and of course, carcinoma, not surprising. None of this is a shocker in the sense of what we diagnosed, but it was the ability to rapidly achieve it, have the certainty that my tool is in it. Equally important that my tool, let's go back to the scan, that my tool wasn't, you know, in a vena cava or right on the pleura, so that I knew right where to take my biopsy in real time, that I could prove that that blue circle, because I just marked it, is the lesion today, not some representation from the CAT scan. So the idea of this next generation image integration, right up front, you first start driving with EMN technology, but you have always on visualization. You're not asked to sacrifice your optics at the time of biopsy, that you can actually see tissue and tool interaction, that you fix CT body divergence with digital tomosynthesis using any fluoro system. Myself in my own lab, I have a 12-year-old C-arm. I think you can see it there in the background. But other labs that have the Galaxy have been using a Siemens Sios. Others have a Philips fixed cone beam. Others have other this is not about which kind. We all have varying systems of fluoroscopy that we've inherited and or purchased. You need to have your robot work with everything you own. You shouldn't be required to go get additional technology to make your first technology work. And so that image upgrade, or that ability to update where the lesion is located, does matter. But the real feature here is the augmented fluoro, the ability to know in real time where the lesion is, and then confirm if you're in there, and then have that precision, because of course you have robotics built in. So I want to show some quick case examples. Now this is an interesting one. We got asked to biopsy this lady with a history of melanoma and Crohn's not that long ago. She's on TNF alpha inhibitor. So boy, the differential's broad here, right? And the CT got done and she had a cough, and you see this nodule, and there it is. So we take her to Bronch, and that's the reference CT, and we do the tilt, and notice you don't really see a lesion. So we do it at a different angle, say, okay, maybe there's some interference with the scope, maybe there's some, but right up front, you can see this lesion is markedly smaller. So we actually do a quick lavage, and we don't take a single biopsy on purpose. We chose not to take a biopsy because we could not see that the lesion was still actually there in the same amount, and it had shrunk. So we get her a follow-up CT basically a week later, and it shrunk. 3 weeks, excuse me. I said 1 week, my error. And the lesion was essentially gone, as you see with your own eyes. Gone. So the tilt reinforced, ultimately, obviously, the clinical picture that the lesion that we were asked to sample was a ghost. Now, another example, because I get asked this often. Does tomosynthesis let you see ground glass opacities? So here's a 16 by 20 right upper lobe GGO. The average Houndfield units was -511. And we ultimately did diagnose adenocarcinoma. I don't think that comes as a big surprise. But what I want to draw your attention to is what the image looks like. There it is. I don't know why the video's not there. I'll have the video play a little bit more. You can see the reference image. There it is on tomosynthesis. Reference image, tomosynthesis. We can adjust the contrast so you can bring it out. There it is. A real GGO using a standard C-arm, the one you see back there. Then what that allows you to do, obviously we got out to the lesion, we take our samples. Here's some other examples of GGO. And then when you look further at GGOs, here's a -565. Here's a -475. Here's one where we forgot to note what it is, but it's clearly wispy. Here's a -672. This was an adenocarcinoma. All of these were adenos. None of this is surprising. But the fact that you can see it, because GGOs are equally important. And we all know you're never seeing a GGO on a standard, 2D fluoro without tomosynthesis or advanced imaging. So here's this GGO, and there it is on imaging. I want to show you, though, what we were able to do and why having this entire integrated package matters so much. So we've navigated out to the periphery. You can see where we are in the left upper lobe. We've updated the lesion location, and now I'm passing a needle through the wall because there's no airway leading into this image. So now you can see tool and tissue interaction. I'm needling through with a Medtronic needle. I'm not required to buy any proprietary instrumentation. I like the Medtronic arc point needle. That's me, and I have no conflict of interest, but I like that needle. And there I am using it. And you can see in multiple planes, I'm in the blue circle. Okay, great. We proved adenocarcinoma. That was not a great surprise. We then dropped a fiducial. But what I want to draw your attention to is that we also took large pieces, because my oncologists like that, with forceps, because there's the needle hole we made. Because I don't have to sacrifice optics, this was the hole I made in the wall to get into the adenocarcinoma that I was then able to pass forceps through and take samples and pass a fiducial delivery kit. I had also been asked to place a fiducial well past it to help guide my surgeons. We can also drop ICG soaked coils for anybody that wants to do then a robotic resection. So that allows you to see the whole time. You shouldn't have to sacrifice what you do for a living. And I want to show you again a great example of vision and precision, because here now this tumor had cavitated and destroyed some of the lung, and so I want to show you the ability to take precise biopsies. There's the tumor. Now I'm way out. The CT, I'm in the right upper lobe, but I'm in that far corner where the fissure and the pleura come together. You can actually see areas of necrosis that you don't want to bother sampling. So we're moving our needle into exactly where we want it to go. Now, this is obviously related to this patient's anatomy and the destruction they've had, but the ability to see, watch your tool interact with tissue, have that stability and precision, and in case you didn't have this view, there's my blue circle telling me where my tumor is, right? So what evidence do we have? So the first paper published out of the group from Australia, Dr. Segehi and his partners, this is really good data from the perspective of one, though they are all amazing endoscopists, this was their first navigation platform. So when people ask me about the learning curve, if you look at their yield ultimately of strict versus intermediate definitions, their one quote miss was their first case. Their average nodule size was 20 millimeters. They had 18 patients with 19 nodules, 11 millimeters from the pleura. They got to every one of them. They could see tool and lesion, and then how one likes to quibble over diagnostic yield. Ultimately, the one that was the intermediate ultimately grew tuberculosis. I would argue that's a positive finding. But there it is. Now, meanwhile, at the recent AABIP meeting, we had presentations from Dr. Sesania and his partners on the Galaxy experience at the Cleveland Clinic, with an average size of almost 13, just under 13 millimeters, with a majority of the patients being under 20 millimeters. So real world, being asked to biopsy small things. And if you look at, nodules were all over the place. Their average amount of sweeps that they did, more importantly, look at their radiation time and their radiation dose. Their tool and lesion rate, 98%, and their diagnostic yield, by the strict definition, was 90%. Now, Dr. Federbush, excuse me, in Agrawal, out at LIJ, 67 nodules in 60 patients. Again, small average size, majority being under 20 millimeters. If you then look from a safety perspective, one pneumothorax, one pneumomediastinum, and then look at the rate at which they had of bleeding. They had their same good navigation, and their yield strict 88 to intermediate at 93. So this again backs up. Now these have been obviously presented, but not published. They're in the works of being published. But what this gives you then is two other centers that also have had extensive experience in multiple platforms, demonstrating the value of having image integration, always on optics, and the ability to then make your diagnosis. Now I'm going to present you my data, which has not been peer reviewed. So feel free to not believe it if you're a pessimist. But what I want to draw your attention to, 233 biopsies. Our average nodule size has been 16 millimeters. 83% though are under 20. 34 have been under 10. 16% have been GGO. So I'm going after small and peripheral. That's what I needed this system for. Most don't have a bronchus sign, as we demonstrated already. 8% have actually been on the pleura. 68% otherwise in the outer third. I distinguish pleura from outer third. So we're going after small and far. The average procedure time, as you see there, now 43 minutes. Now this is interesting. This is a range, and that's full inspection. But we're also a teaching hospital, and I purposely let my fellows from day one, they drive the system. So on the days that the fellows are not there, and all due respect to our fellows, our average procedure time is about 15 minutes. When the fellows are there, I give them the time to explore. And I hope everyone on this call spent a lot of time fighting very hard to not steal the scope from them. Average fluoro time is 6 minutes. Average radiation dose is 20 milligram. Now that had been higher because we would do our tilt and then we never turned down our dose. Now after the tilt, fluoro, other than augmented fluoro, the fluoro is relatively useless. So now we immediately hit low dose, and so our average radiation dose keeps plummeting. And so since we've made that change, we keep using less and less. But more importantly, using a strict diagnosis definition, our yield at our center has been 95%. Now, there's a lot of different potential reasons for this. I have a lot of different ROSE-based technologies, because for me, though, the real secret has been that because I see the lesion on tilt, I know there's no debate where the nodule is. I get my updated targeting, and then I get augmented fluoro. And I am going to put any instrument inside that augmented fluoro circle, whether that's a needle, whether that's a forceps, whether that's a cryobiopsy. If I don't like any of my prior results, I'll use somebody else's needle and someone else's forceps. I'll grab my cryobiopsy, whatever, but I will not stop until there's a diagnosis because I've seen the lesion. There's no debate I've found it. There's no debate I'm there. We're going to keep going until I make a diagnosis because there's no reason to quit. You saw it. You made it there. So I'm going to end there and put up my contact information quick. Say thank you. Here's Chicago. There's my hospital. There's my contact information. Feel free to find me on via social medias and blah, blah, blah. And otherwise, thank you so much for your time. You find yourself in the Chicago area, give me a call, a heads up. You're welcome to come by and see cases anytime. And otherwise, thanks so much. Emily's going to kick me off, and now Jason's going to take over.
Thank you, Kyle.
Good to see you, Jay.
It's really great to see you as well. And so thank you for the opportunity to speak with you all this evening. It's an honor to follow Dr. Hogarth, someone who I worked with for 13 years at University of Chicago Medicine, and I appreciate his compliments at the beginning. But my goal today is to spend the next 20 minutes or so running through the perspective of the C-suite, right? So Dr. Hogarth just walked you through, very aptly the reasons, the clinical reasons to go with a robot. Now, I hope to help you with your messaging to the C-suite as the why behind going with a robot. So before we get going, I also would say that I am a paid executive advisor of NOAA Medical, so there's my disclosure as well. So I really want to walk you through 4 key points this evening. The first is articulating the challenge of lung cancer and the treatment of lung cancer and lung nodule programs. 2, I want to describe the opportunity because I believe there is really an opportunity here, which is why when Kyle presented me with the opportunity to be the first to bring NOAA to University of Chicago Medicine, I felt it was a no-brainer. I hope I can help you with getting your executives to feel the same way. And then I want to talk a little bit about what I believe are the economic benefits of the Galaxy system in particular. And then I want to finish out with just a quick discussion around making sure you align your message with the strategic priorities of your organization. And before I get into the challenge, I would say, and Kyle sort of hit on this, the challenges of the C-suite are real, right? So we're faced with rising cost pressure, both from the supply and non-labor side, but also on the labor side. We're finding, reimbursement declining seemingly every day, and so margin pressures are real. We also have real challenges to grow in scarce capacity, and so finding programs that make sense both from a clinical point of view, which I think Kyle has made that case, but also from a business point of view are really, really important. So with that, and I will say, as I'm presenting you these slides, I know you all know this, but I'm just saying these are things that I feel like will be important as you're sharing with your executive team to help them make the case for making an investment in robotics. So, for me, almost stopped here when Kyle and others have reviewed data like this with me. I'm ready to invest after looking at a slide like this. So 1 in 16 Americans diagnosed with lung cancer, 25% of all cancer deaths from lung cancer, first leading cause of death amongst men and women from cancer, and the second most common cancer in men and women. And then in 2024, 235,000 estimated new cases of lung cancer and 125,000 estimated deaths, and a 5-year survival rate as it currently stands of 26.7%. So the case is real. So currently there are 2 common pathways for identifying potential lung cancer patients. The first is incidental lung nodules. Patients underwent 4.8 million CTs in 2014 or 2024, sorry. And patients identified with incidental lung nodules were at 1.57 million, right? So a large number of patients who are undergoing just a regular chest CT, you're finding lung nodules. The question is how many of you believe that you're doing everything you can without 1.57 million? And I would say in my experience, University of Chicago Medicine and other places is we're leaving a lot of these patients on the table and not following through in the way that we can. So I think there's a real opportunity to tackle that 1.57 million. And then moving over to screening detected lung nodules, 14.2 million Americans eligible for screening, and only 550,000 actually getting screened. So when you look at market and market opportunities, you know, a big thing in the C-suite is to talk about market share. And the great thing about this program for me was that you don't have to steal market share. It's always fun to steal market share from your competitors in the local area, don't get me wrong, but in this instance, you don't have to. What you have to do is convert the patients on the left, the incidental findings, and get more patients through the screening process, so then you can get them into the diagnosis channel, do the things that Kyle just mentioned, get them to pathology, and then on to medical treatment. So really, really huge opportunity for the number of patients that we can serve, and serve much better than we are today.
Jason, that's an argument for like lung nodule tracking software and nodule navigators, because these all represent, from a C-suite perspective, financial opportunities as well. I mean, obviously patient opportunity is what we care about, but we got to keep the power on.
Exactly. So, but there are challenges, right? So early diagnosis, we know, can save lives, and to your point, Kyle, can drive revenue, but several challenges exist with getting that early diagnosis. The first is really patient dependent. So patients may be in denial and say, yeah, you know, I smoked, but it's been years ago. I don't really need to get that CT, or just the stigma of, yeah, I've got a little cough, but I'm sure it'll go away. It's probably nothing, right? So patient dependent, protocol dependent. And so Kyle, you know, you know, we've talked a lot about lung nodule programs and development programs. So ensuring that you have a protocol that when you have the incidental finding, there's someone following up with that patient to ensure they get that next step in imaging if necessary, to ensure that that nodule is not cancerous. And then lastly, and I think what we're focused on today, is lesion dependent, right? So oftentimes these are very small size, they're challenging in appearance, they're hard to get to, right? And so Kyle, I think in his case example, showed you know, the advantages of the Galaxy robot in allowing us to get after more patients than we've ever been able to before. You know, these were patients that used to be sort of wait and see, you know, come back and we'll, you know, scan you again to see if the lesion's big enough that we can get after it. Now we can't, right? So it's really opened up a whole nother avenue to being able to diagnose these patients earlier. So now I want to talk a little bit more, you know, for me, challenges are opportunities, but I want to dive a little bit more into where I believe the opportunity is with a lung nodule program along with robotics. So 75% of patients are undiagnosed or late diagnosed, so stage 3 or stage 4. And we feel like many of them can be diagnosed sooner, and we know that when they're diagnosed sooner, prognosis is much greater. So, you know, the advantages of a robust program with screening and incidental findings and tracking incidental findings is you have more patients in the funnel, as I've already discussed. The value of a robot such as the Galaxy allows us to get the tools that Kyle has just mentioned in more hands, right? The fact that there's not a barrier to entry from capital to be able to hook onto your C-arm, the fact that, you know, this is, and I'll dig into this a little bit more in future slides, that, you know, that the cost is not so great that others can't get in. Site expansion, there's, you know, opportunities to get into ASCs potentially with the robot and open up capacity that we currently are not utilizing. Currently, most bronchoscopies are done in a suite such as Kyle's, or God forbid, in an operating room. And to be able to expand at a fairly low cost into sites like ambulatory surgery centers is a real opportunity. And then operational efficiency, right? So to hear Kyle talk about being able to do these bronchoscopies and walk away with an answer in 15 minutes is just amazing to me, right? And I think it's something that as you go to talk to your C-suite executives, you can sell the benefit of getting more patients through what is a scarce resource, either in your lab or in your operating room. So expanded patient access, increase in procedural volume, increase in market share, even though I said it's not really even necessary because there's a lot of the market that's unserved. And then, most importantly for me and hopefully your C-suite is increase in patient experience and outcome and, better provider experience as well. So diagnosing earlier. So something I talk about a lot is with programs like this is, what's the downstream impact? Like clearly we can do the finances on what Kyle is earning in the Bronch lab. That's pretty easy. But then the question is with a robust screening program, with a robust incidental finding program, you're going to find more nodules, which then lead to more advanced imaging, MRI, PET, pulmonary function testing, which then leads to more diagnostic bronchoscopies, the ability to do more diagnostic bronchoscopies on very difficult lesions in tough locations. It's just going to increase the numbers coming out of the bronch lab, and numbers coming out of the bronch lab are going to pass downstream to equate to more radiation and chemo, more thoracic surgery consults, and more surgery. And then not to mention that there will be follow-up imaging with CT scans every 6 months. So there's a lot of opportunities here to grasp downstream revenue from a very robust nodule program and a bronchoscopy suite that is functioning and is able to take patients that previously haven't been able to be cared for. So, and we all know, and I know I'm preaching to the choir, that reducing the time from identification to diagnosis is going to improve outcome and overall actually lower costs, which is something that's very important. And I think as a case to be made with insurance companies, I like Medicare sort of gets it and they're sort of prioritizing this, but I think there's a lot of opportunities to educate our insurance companies around the value of diagnosing cancers, all cancers, but lung cancer specifically earlier. Now I want to talk a little bit about the solution being the Galaxy robot and what I found to be the economic benefits and really what sort of sealed the deal as Kyle was coming to me to present the business case to bring the Galaxy into University of Chicago Medicine. And I would say, the business case matters, right? So as a C-suite executive, I was tasked with annual capital budget of around 60 million and over $300 million worth of requests, right? So sifting through those requests and understanding which ones really, have the clinical benefits, but also the economic benefits was, a real challenge. And I think it's up to you all to help educate your executives on why this is a program that they should invest in. So with that, I'm going to talk a little bit about 3 parts of the Galaxy system. One, Kyle already hit on this, integrates with most existing 2D and 3D C-arms. I told Kyle, getting the Galaxy was the last time I heard him talk about the need for cone beam. Before that, it was like every time I saw him in the hall, every capital request cycle, I had to turn him down because we just couldn't fit. We couldn't make the business case to get a cone beam CT. Once we brought in the Galaxy, he's really happy to talk about that 12-year-old C-arm that he has. It's probably 13 years old by now, Kyle, but it's doing the job. Clearly, we just
bought it
right?
for the first year.
Yeah. And then I'll talk a little bit about single-use disposable scopes, which have many, many advantages, and then the small footprint that the Galaxy system brings. So I don't really need to hammer this home much more, I think, but the ability for the Galaxy to integrate with your existing 2D or 3D, if you're lucky to have one C-arm, no matter what brand, I felt like was a huge advantage, right? And so we didn't have to make an additional investment on top of the investment in the Galaxy robot. We were able to plug and play with our existing C-arms. I think it gives a lot of flexibility for organizations to be able to do that. You can move the robot around, you can move it to the OR if you need to, you can move it from lab to lab if necessary, and you're not incumbent on ensuring that you have a certain kind of imaging, you know, a 3D or a cone beam type of imaging capability. So I already mentioned this, it avoids the need to invest, you know, at least $500,000 for new imaging. And then the flexibility for imaging integration reduces your scheduling challenges, as I already mentioned. And I will say, in talking to our teams in Kyle's lab, the ease of the plug and play and the usability of this system, you know, the teams rave about. Oftentimes you bring in a new technology and the staff are, you know, disgruntled, and it's a new sort of toy I've heard used, and, you know, it's tough to use, it's tough to integrate, and, you know, everything I've heard about the NOAA system is it's really intuitive, and you know, probably shouldn't have used that word, but easy to use. The user interface is really easy, and so I think that's an important part, because you want your team to be able to you know, efficiently use the system. And I will add that Galaxy is currently the only robotic bronchoscopy solution that integrates with most existing 2D and 3D C-arms. So I think, you know, just to reiterate that. And now moving on, I want to talk a little bit about single-use disposable scopes. So, you know, one of the challenges of, you know, bronch labs, GI labs, is the need to reprocess scopes, to hire the staff, the time that it takes to reprocess the scopes, the cost. So here we have an estimate of $114 to $280 every time we have to process an endoscope. And of course, we know reprocessing comes with cross-contamination risk. So at a 2.8 cross-contamination rate, you're talking about, you know, $29,000 to cost or treat an acute respiratory infection that we caused. So none of us want to be in the business of bringing a patient in to treat them for one thing and having them leave with another, right? And so anything we can do to avoid cross-contamination and infection risk, I think we should do. And so, you know, you're currently looking at the only disposable scope in the robotics industry. So I think that's a really, really important point that shouldn't be minimized. And then there's also the impact to the environment, right? So reprocessing adds 80% higher CO2. And then also a 90% higher energy requirement to do reprocessing. So there's a lot of advantages. You know, as I walked into this, I was concerned about, well, it's disposable. Are we going to be creating more waste? But as I really dug into the numbers and read things like this, I understand that there's actually a lot of benefit to the environment in going single use.
You know, those numbers add up. We do 5 or 6 of these a day. So those processing costs are real.
Exactly. Exactly. And all of these, Kyle, help build into the business case on top of the revenue, the downstream I already spoke to, and are all critically. And those are hard green dollars. And I always talk about soft green and hard green. That's real savings. And it's easy to quantify. And when you're talking to your CFO or your COO, whoever your decision makers are, being able to quantify the hard green are what's going to really sell this. And then lastly, I want to talk a little bit about the small footprint, right? So 6.3 square feet, right? So it takes a very, very little, you know, footprint. Everything is, you know, the screen, the robot is all mounted on a single cart, takes up a very, very small amount of space. And earlier I mentioned the opportunities to launch a program like this in an ASC. We all know that ASCs tend to have smaller operating rooms. And so this smaller footprint versus the competitors, 6.3 versus 10.7 versus 12.75, is an advantage, right? And so, you know, even in Kyle's labs, which are nice size, it's great to actually have some room to move around and not have to step over cables that are plugged into monitors, and to have it nice and tightly integrated. So as I mentioned earlier, it's easy to stow, it's easy to set up, it's easy to clean. So it really, really fits well into your lab or OR space. And once again, Galaxy only robotic bronchoscopy system with monitor, arms, and control, all integrated into a single unit. So clearly an advantage there. So talking a little bit about the advantages of the higher diagnostic yield, and I'm not going to go into detail here because Kyle did a great job of nailing this, but with a reported yield of up to 95%, you end up with more patients diagnosed earlier. Earlier diagnosis means more surgical treatments, more novel therapies are available. And in this study, surgical resection generates an average of $41,500 in reimbursement, right? So when I talk about hard green, that case wouldn't have happened without the early diagnosis, using the robot, and then the referral to the thoracic surgeon to get that case done. So, these things really, really add up rather quickly. And the case to make the capital investment, to me, ended up being a really, really easy decision. I don't get many of those. So the last thing I wanted to talk about is this transitional pass-through payment, or TPT. So I mentioned earlier that CMS sort of has been leading the way at new and innovative medical techniques. One of the things that CMS is really trying to eliminate is intra-hospital infections, and so they are actually incentivizing single-use pulmonary bronchoscopes. And happy to report that the Galaxy bronchoscope qualifies for this TPT payment, which I'll talk about in a little bit more detail here in a minute. It's a 3-year sort of award, so there's another couple years left on the TPT payment. So not only are you using the disposable that has the benefits I mentioned earlier, but you're actually able to bill for it. So talk a little bit about how, I know your guys' eyes may glaze over a little bit as I talk about a little bit of finance here, but just a little bit about how the TPT process works and the calculation, because this will be important. And of course, the NOAA reps can help walk you through this and the particulars for your institution, but just to understand the basics, I think is important. So the coding process is the same as usual. So you're coding for your outpatient procedure, for the bronchoscope, and then you're adding the C code, which is C1601, which is the transition, the TPT payment. And then the regular payment along with the TPT payment is your total payment received. So the calculation goes like this, and this is healthcare economics. Don't ask me why it works this way, but you set a device charge based on the cost of the device plus a markup. You then multiply it times your cost to charge ratio, and every organization is going to have a different cost to charge ratio with Medicare. So you'll need to understand what that is. You set your charge, you do that multiplication, you offset the device offset, which I'll talk about in a minute. You get your TPT payment plus your APC payment, and that's your total reimbursement. So now to make it real, and this is just an illustrative example. So as I mentioned earlier, you start with billing for the bronchoscopy, CPT codes 31629, 31628, and then you're going to add on the C1601, which is the TPT. And this example, they set the charge at $7,500. This particular hospital example's cost to charge ratio was 0.2689. So the multiplication there, A times B, gave a reported cost of the device of 2017. Don't ask why we wouldn't just say what we paid for it, but we want to make things hard when we're dealing with the government. So in this instance, it's $2,017. And then there's a device related offset. So in this example, the CPT code above 31628 already had a $45, thank you very much, Medicare, $45 cost of doing the procedure related to the equipment and device. So you have to subtract that because they're now paying you $2,017, and so your new incremental TPT payment in this example is $1,972 plus your normal APC assignment of $6,528. So your new ability to collect is $8,500. So by having TPT for Medicare and a disposable scope, you're able to collect an extra almost $2,000 in this example. And so I use this as an example. These are fictitious numbers. You would have to work with your CFO or your finance team to really understand how you set your charge, what your your cost to charge ratio is, and then it's pretty easy math after that.
Jason, can I add one quick thing to add some color to this, which I think you'll be happy to know since you approved us getting the Galaxy.
Yes.
So we just got our contribution margin. So, that's the fancy way of saying essentially the profit from the bronch. And as Jason was highlighting, downstream revenue, which is clearly very important, but I think you'd agree that there's sometimes, unfortunately, chief operating officers that don't look at downstream revenue. That's a silent argument for some of them. And
Right.
they expect you to be profitable by yourself as a business unit. So we are our contribution margin at the University of Chicago for every Galaxy we do averages $3,000.
There you
So
go.
we did 5 robots the other day. That's 15 grand. That's net profit. So when the medical center tries to tell you we don't have budget to buy you other equipment you think you want or whatever comes along, yeah, they do.
You're armed and dangerous, Kyle. Armed and dangerous. But that's a great point. The great thing with the TPT payment is the Bronch Lab can stand alone and does create margin, right? And so then if you can make the business case to buy the robot just off your Bronch Lab business alone, and I think I've shared with you opportunities to grow your Bronch business, then this makes it a lot easier. And then all of the downstream is just icing on the cake, right? So I think that's a really important point for you all to understand what your contribution margin is and work with your finance team to understand that and be armed with that before you have these sorts of conversations. So just real quick, summary of the economic benefits. So I've already, I think beat this to death. So the 2D, 3D C-arms, it's going to be able to interface with it, whatever systems you currently have. So should avoid a capital, expenditure of around $500,000. We talked about the $20,000 annual cost of reprocessing, and that's just an example. It could be much greater than that. And I think in a busy lab like Kyle's, it certainly is. The avoidance of potential 29K per occurrence of infection treatment costs. The 6.3 square foot radius of the unit occupies less space, allows it to sort of fit in with all of your other equipment, work in small spaces. And then the icing on the cake is the TPT payment, which I will add is only available for Medicare, but that's about 50% of your cancer patients or your potential patients. So it's a big, significant piece. And I do believe there's opportunities to work with your local insurance providers to help convince them that paying for this upfront is advantageous for the long run as well. So this is a system that's clinically proven to provide high diagnostic yields and will drive downstream revenue in addition to the revenue within your lab. And then lastly, I wanted to talk about strategic priorities of the facility. So I think it's important as you start to engage with your senior leadership team that you take a step back and you look at the mission and vision of the organization. I would argue that any organization you're working for, treating patients with cancer and improving the outcomes of patients with cancer is going to fit. So I don't think you're going to have a hard time connecting this to your mission and vision. I would also say understanding the operational priorities. So what makes your C-suite tick? What are they trying to do? And I would also say that most are trying to grow cancer in my experience. And so this should fit well with what their priorities are and strategic vision is for the organization. Be mindful of budget planning schedules. So I think Kyle has learned the UCM planning cycle and trying to get in line with whatever your fiscal year, your capital budget cycle is. It's much harder to get something like this through out of period because it's generally coming out of contingency and people like to hold on their contingency for emergencies. So making sure you're timing your discussions with your C-suite around the budget planning schedule so that you can actually get in line and ideally on the approved list so you don't have to go ask for contingency. And then this last one, and I would say I was incredibly lucky to have a partner like Kyle on the clinical side, but for you all who are physicians, finding that administrative executive who's going to be your partner, who's going to champion this for you is absolutely critical. You've got to find that person and take the time to ask around, find out who's making decisions around prioritization of capital, become their best friend. So with that, I wanted to say thank you. Thank you for your time, and I think we have a little bit of time left for questions.
Let's see what.
Yeah, thanks, Jason. Thanks, Dr. Hogarth, for an excellent presentation. Right now, we are going to open up to questions for everybody. As a reminder, if you have any, you can submit them using the question feature, and Praj will come back on. And also up on the screen, you guys can both see the speaker's contact information if you have any further questions. So Praj, I'll hand over to you to do the questions before we wrap up.
Uh-oh. You there, Praj? Can't hear you.
Oh, come off mute.
I apologize for that. Can you guys hear me now?
Yes.
Okay. Sorry about that. So I was saying thank you so much to Dr. Hogarth and Jason for the wonderful presentation. We have a few questions that have come in during the presentation. First one is to Dr. Hogarth. Can you talk a little bit about what training you got before you started using the Galaxy system?
Yeah. So they take you through a formal course. Maybe this has changed within the company, but I was flown out to California. We did a cadaver lab. I did mock-ups and mannequins. We practiced on the software. So basically, I was given obviously the opportunity to make myself up to date on the uses of it. I do know, because I've served as one of these people, that also proctors can be brought in if needed. So if a new center does not have a lot of peripheral experience, or maybe the medical center might have its requirements on levels of proctoring, there's different rules. NOAA will obviously help proctor, but there's been a small analysis of data on this out at UC San Diego, and it looks like about 10 cases. So it's not a steep learning curve. I actually will jokingly tell you that my job has been reduced to go put an instrument inside a blue circle. That's pretty easy. I was always good at carnival games. And so, bronchoscopy is not all that hard anymore. I say that half jokingly.
Thank you so much, Dr. Hogarth. Another question for you. What instruments are compatible with the scope?
Yeah, anything that will fit down the length of the scope. So, all the peripheral instrumentations, if you like Olympus's PeriView Flex or the Arc Point needle from Medtronic, or you're a big fan of the Bronchos needle, anything fits down. So that's the other thing that's great, because my partners and I, with no data behind it, like one instrument or another, this forceps, that forceps. I know people that are cryoprobe only. Great. Nobody cares. It's a 2.1 working channel with optics that you can see. So put down what you like, what maybe your hospital got a good deal on.
We might care if there's a big cost difference. But
the instrument doesn't care. So there's the beauty of it. I mean, and I think the fun part is, so we've been part now of several trials also for therapeutics. And because this allows you to target the center, we obviously didn't have slides on this, but we've been able to inject directly into the center of the tumor various therapeutic, all part of clinical trial, right? To be able to help also in the management and treatment of lung cancer. Now, all these are obviously investigational, but to be blunt, I don't really care what ultimately wins here on the injection, or inject this, or place this, or deploy that. I just need to be able to get to the lesion. I need to be able to get into the center of the lesion and then turn on or inject or do whatever. So I'm happy to be part of the research. And if the things that I'm currently working on in these trials work, awesome. Then I've got now an easy conduit to immediately help my cancer patients at the time of diagnosis. Love it.
Thank you so much, Dr. Hogarth. Next question is for Jason. You touched a little bit upon business cycles towards the end. So the question is, what are usually some business cycles for budget planning? As in, what is the typical time of the year that this happens?
Yeah, I think it depends on whether the organization you work with is on a calendar year planning cycle, or like an academic year. So generally, whatever the fiscal year is that your organization observes is what the planning cycle is for capital. And I would say anywhere between 3-4 months ahead of that is probably when the planning is occurring. So you'd have to ask around of your finance team of exactly what those dates are. Some places do a better job of publishing those. your local leader of your bronch lab may know that. If not, they should. And I would encourage them to figure that out for you. But yeah, it really usually coincides with whatever the fiscal cycle is for the organization.
Praj, before you ask
Awesome.
the next question that came in, I want to remind Jason of something that he may not even remember this conversation because it was like a decade ago. But he pointed out that physicians, all of us across every profession and within medicine, we see something new, we've watched a video on it, we played with it at a show, we're like, oh, this is amazing, I have to get this for my whatever I do. And so all of us pester the C-suite on a daily basis asking for billions of dollars, and some of which is for garbage. And so, as he highlighted, you need to come in with real information, and this technology easily makes that. This was the easiest pitch I think I ever made to Jason. But one of the things he told me early on, he goes, when someone walks into my office for the first time ever and says, I want this, he's like, I don't even listen. I don't even take notes. They walk away and I never hear from them again, which clearly means they did not even want it. They played with it once, thought it was cool, like a shiny new toy, like your child with a Lego, and off they went. He said, but when they come in a second time, I at least take a note or two, really don't listen, but I pay an ounce of attention to see if this lines up with the strategic mission of our place. And then they leave. And if they actually show up a third time, I ask for a business model. And so the point there being, and I don't know if you remember the story, Jason, but it was a key insight, which was like, if you want this, like, you got to do your own work. And you've got to like not just be passionate about the medicine side, because Jason's passionate about the medicine side, but he's also got to be passionate about the money side. And so you've got to develop that business model. So what I always did was when I would contact his secretary, I'd schedule a meeting on June 1st, July 1st, and August 1st. And that way on August 1st, he knew he was doomed.
Kyle also did a really good job of educating me. He had me in the lab, he spent time with me, he invited me to business reviews with prior vendors that we had worked with. So I was a pretty educated consumer. And when he came to me with this technology, I trusted that this was the right investment. It wasn't the first time I'd heard from him. So I would encourage you to start building those relationships, even if you don't have an ask. Because when there is an ask, it goes a long ways.
Awesome. Thank you so much to both of you. I do realize that we are about 5 minutes over time, so I'm going to ask one more question. We do have a few more questions, but I'm going to ask one more in the interest of time, and I'm going to leave this screen up here. Should you like to reach out to Dr. Hogarth or for Jason with your questions, please do so. They've been very kind enough to share their contact information with us. So the last question that I want to ask is, I think it could go to both of you. How can I quantify downstream revenue, TFT, CT, chemo, surgery, etc., that my bronch does to justify my case?
I'm actually dying to hear Jason's answer, but I'll tell you what I do, which was easy. So anybody who's new to the university gets a new medical record number. And if what I did is I tracked my downstream revenue in 2 ways. If I did 100 bronchs, how many of them were the first time they entered the University of Chicago was because of me? That they found me on the internet, or their doctor found me and sent them. So it's one thing that I'm took care of a patient that's already built into our system. That's real revenue too. But I wanted to demonstrate that I was a program grower, that I brought more business to the University of Chicago. And then what I would do is then track. And sure enough, like Jason said, CT, PFTs. And then what was also interesting was the number of times you see the patient also saw cardiology, and then started seeing one of our endocrinologists. And so that they basically came to the place and they're like, oh, this place is kind of nice. And so you were able to actually bring in the total patient, right? And I never got around granular enough to then see if we started capturing brothers, sisters, and mothers and fathers, but I assume we did. And so that was my easy way to say me, not, again, not like, it's great to take care of an internal patient, but I brought this patient here.
Yeah.
Therefore, this is my money, if you will. So therefore, when I ask for things, this is what I bring to you.
Yeah, no, I think that's exactly how you do it, Kyle. So if you were the index case, like this patient did not interact with you, that's by far the cleanest, right? They came to see you, they came to your bronch lab, you diagnosed them, and then especially anything cancer related is directly in your lane, and you should be able to take credit. I mean, the problem with downstream, and the reason a lot of executives are reluctant to give credit for it is that everyone wants to claim it. and it gets claimed a million times. So in cancer especially, UCM is building a new cancer hospital. I can guarantee you everything that Kyle's done and everything that everyone else has done is all going to prove out that pro forma. So that's the challenge. But I think that the way Kyle defined it is exactly how I would encourage you to do it.
Awesome. Well, thank you so much to both of you. I think that we are now out of time, and we've had some wonderful questions come in. So I appreciate the audience for the initiative. I want to close out now by thanking once again Dr. Hogarth and Jason Keeler for the fantastic presentation. The webinar is being recorded, and it will be available on the Society of Advanced Bronchoscopy website, as well as eventually onto the NOAA medical team's website as well. So thank you, everyone, for joining in. I hope you have a wonderful rest of the day and rest of the week.
Thanks, everyone. Happy holidays.
Thanks so much. Thanks, Jake. Thanks, Praj. See ya. Bye, Emily.